Hello again, everybody. Let's talk about insurance and reimbursement. This is part 5A of Unit 1. There is an entire complex world that deals with all things insurance and accounts receivable. So let's talk about it. Patients with health insurance pay a set premium, usually every month, to have the insurance company cover their healthcare costs. When physicians complete a service, they can bill an invoice to the insurance company, which pays the physician on behalf of the patient. Patients can contact the insurance company to pay for services rendered by a provider request, which we call a claim. Sometimes it happens automatically when the provider staff sends in claims. However, insurance companies have terms and conditions in order to be covered and may deny coverage to patients for various reasons. Sometimes you just have to navigate the American healthcare system. Managed care was developed to combat rising healthcare costs. Basically, managed care is what we would consider health insurance. This is accomplished with built-in cost controls. The only payment providers receive is from the prepaid pool, regardless of services, which are types of service and frequency. People who subscribe must use that specific group of physicians that are contracted with the insurance company to be covered. The copay, or the amount due at the time of service, is a set amount that providers get that day. Some providers are paid in capitation, which is a fixed fee for all patients no matter what is done for them. The overall goal of a prepaid plan is that the cost will eventually average out. Some patients see the physician more than others, and that may eventually change as the generations grow older. Some people do worry that the cost containment pressure will conflict with the quality of care, that they won't get the best service or help available because the insurance won't cover it. They also worry that the number and kind of services will be sacrificed in order to increase profits. There are some efforts to pass legislation to protect patient access to appropriate care. Negotiated fees are fees that are predetermined between insurance companies and providers. The negotiated rate may cover all or only part of the provider's actual charges, so the patient may also incur some of the charge. Limitation of access, or saying which patient can get what access to treatment or not, ensures that the insurance company can cover its cost, but it also leaves people who are most in need of health care without cost coverage, especially those with pre-existing conditions. This method has people looking towards a national health care plan so that everybody can be covered, also known as the single-payer plan. And currently the model for that would be Medicare for all, but it's not really anywhere near going to be approved. Restriction of usage methods are used to reduce the overuse of services by patients. Insurance companies can be very clever to find just one little thing that violates their terms of coverage, and that's it. Some insurance companies will take away the patient's CPAP if they don't show that they are compliant. Everything starts at the primary care provider, or PCP. The PCP is the one who can provide a specialist for their patient as a referral. They are called the gatekeepers because they hold the key for a patient to get a specialist. They will look at the big picture of overall health, their history, and their needs, and provide referrals based on those different things. One downside for PCPs and their patients is that the patient still has to have an appointment with the PCP to get to a specialist, and then the PCP might want to have a follow-up with it, as well as the specialist might want to follow up. That's a lot of time and money. And so it's important for healthcare workers to know which companies also require pre-authorization. For instance, if the insurance company needs to be contacted before a sleep study is done. That would be pre-authorization. When I was working in the labs, Blue Cross Blue Shield was famous for not requiring pre-authorization, and you could just get a sleep study, no big deal. An HMO, or Health Maintenance Organization, is an entity that provides, offers, or arranges for coverage of designated health services needed by a member for a fixed prepaid premium. HMOs offer prepaid comprehensive health coverage for both hospital and patient and outpatient physician services. The HMO is paid in monthly premiums or capitated rate by the payers, which include employers, insurance companies, government agencies, and other groups represented covered lives. The HMO must meet the specifications of the Federal HMO Act, as well as meeting many rules and regulations required at the state level. There are 4 basic models: the group model, the individual practice association, a network model, and a staff model. An HMO contracts with healthcare providers like physicians, hospitals, and other health professionals. The members of an HMO are required to use participating or approved providers for all health services, and generally all services will need to meet further approval by the HMO through its utilization program. Members are enrolled for a specific period of time. HMOs may turn around and subcapitate to other groups. For example, it may carve out certain benefit categories like mental health and subcapitate these to a mental health HMO. Or the HMO might subcapitate to a provider group, or provider network. HMOs are the most restrictive form of managed care benefit plans because they restrict all the procedures, they restrict who you can see, and they restrict what your benefits are. An exclusive provider organization is a plan that or an EPO is a plan that limits the coverage of non-emergency care to contracted healthcare providers. It operates similarly to an HMO plan, but is usually offered as an insured or self-funded product. Sometimes it looks like a managed care organization that organized similarly to a PPO, which is a preferred provider organization, and we'll talk about that in a minute, in which physicians do not receive capitated payments, but the plan only allows patients to choose medical care from network providers. If a patient elects to seek care outside of the network, then he or she will usually not be reimbursed for the cost of the treatment. It uses a small network of providers and has primary care physicians serving as care coordinators or gatekeepers. Typically, an EPO, exclusive provider organization, has financial incentives for physicians to practice cost-effective medicine by using either a prepaid per capita rate or a discounted fee schedule, plus a bonus if cost targets are met. Most EPOs are POS plans, payment of service plans, because they pay for some out-of-network care. And to the PPOs, preferred provider organization, some combination of hospital and physicians that agrees to render particular services to a group of people, perhaps under contract with a private insurer. A healthcare delivery system, it's a healthcare delivery system that contracts with providers of medical care to provide services at discounted fees to members. Members may seek from non-participating providers, but generally are financially penalized for doing so by the loss of the discounted rates, and the insured population may incur out-of-pocket expenses for those covered services received outside the PPO if the outside charge exceeds the PPO payment rate. A PPO can also be a legal entity, or it may be a function of an already formed health plan, HMO or PHO. The entity may have a health benefit plan that is also referred to as a PPO. PPOs are a common method of managing care while still paying for services through an indemnity plan. Most PPO plans are point-of-service plans in that they will pay a higher percentage for care provided by providers in the network. Most insurers will offer PPOs as well as HMOs. Generally, PPOs will offer more choice for the patient and will provide higher reimbursement to the providers. Medicare is currently the government health insurance program that guarantees health insurance for people aged 65 years and older, as well as those who qualify for Social Security benefits, which is generally people who are profoundly mentally or disabled or mentally impaired. In fact, Medicare began in 1965 and is a part of the Social Security Administration. The main entity that governs Medicare is called the Centers for Medicare and Medicaid Services, CMS. Medicare has a prescription drug plan which was expanded in 2003 with the MMA. No, not that MMA, but the Medicare Prescription Drug Improvement and Modernization Act. There's Part A, which covers hospitalization, home care, and hospice, and Part B, which is your run-of-the-mill primary care provider, outpatient services, urgent care, sleep studies, things like that. May I also take this moment to interject, dear sleep friends. The Medicare stuff that we're learning right here is pretty important. You want to know that stuff because that stuff doesn't really change and it's all very uniform. But when we're talking about HMOs, PMOs, and all that stuff, get the general idea of it, understand the basic differences. We don't need to understand it like we need to understand filter settings or real big sleep stuff. The reason we're covering this stuff is because they might have a question or two on the exam about these kinds of things. You also need to know where the money's coming from that you're getting paid. And if it takes all this work just to get you paid for, getting patients help, maybe we should change that kind of stuff. That's why health insurance and healthcare is such a big deal in the news right now. Anyways, Medicaid is the government program that is for people who can't afford health insurance because of low income, and it's also for some partial disability patients. Medicaid is a state-level resource, so people are at the will of their state and their state lawmakers. Who gets help and who doesn't it's different from state to state. Since the government provides funding through these programs, it plays a big role in regulating the cost and quality of health care. This is the important stuff. So, like, if one lab charges $2,500 per study and another charges $3,000 for a study, they'll both only receive what Medicare is reimbursing. Hospitals that charge less than what Medicare pays get to keep whatever is left from the surplus. Those that charge more must incur the charge themselves from the cost. Because of Medicare guidelines, they may limit hospital stays. They usually only cover generic drugs. Medicare also has rules about desaturations. A person who does not have Medicare, you can score their hypopneas with just an arousal or just a 3% desaturation. Medicare is required to have a 4% desaturation, period, and that excludes a lot of patients from getting CPAP. A lot of other healthcare plans jump on board when the regulation of facilities and say they won't cover the services unless the facility is certified by Medicare. Nursing and geriatric assistants must go through certain regulations to maintain their compliance. As a sleep technologist, you may work for a facility that takes Medicare patients. You will have to go through annual Medicare compliance training to make sure you and your lab follow the rules. Medicare fraud is a huge deal, and they reward big time as an incentive for people so that if they would speak up and say something is happening in one of their facilities. There are debits and credits for any business, meaning money going out, which is accounts payable, and accounts receivable, money coming in. Accounts payable is money going out for supplies, power, water, facilities, and accounts receivable is money coming in from patients or insurance companies for services rendered. The facility wants to keep accounts receivable low. The cost of money. That's basically a facility loses money because they have outstanding debts owed to them. That money, if they had it, could be earning interest. This is really getting into accounting and financial management, which is what my wife excels in. Personally, I can't stand anything of the business side of things, like putting value on services, because how do you really do that? How do you put a price on health? How dare I opine? May I be struck down? I apologize. Coding. Coding is a huge deal. It provides information on which payment of insurance claims are based. We're going to go over all that stuff specifically in the next presentation, so go check that one out. All right. This stuff is kind of dry. We're going to get to really exciting sleep stuff eventually. Just stick with it because insurance is just what it is right now. Hopefully it changes so that patients can get what they need and sleep technologists can keep getting paid what they need to. All right. We'll talk to you next time.